Okay, welcome everyone. Good afternoon, and thank you for coming to this lunch hour lecture at UCL. My name's Judith Stevenson. I work at the Institute for Women's Health at UCL, and it's my great pleasure to introduce my friend and colleague, Professor Usha Menon, who's going to give today's lunch hour lecture. Usha is head of the Gynaecological Cancer Research Centre at the Institute for Women's Health here at UCL, and she is going to tell us about a long journey working on one of the largest randomised trials ever conducted across the globe. And this is a trial about screening for ovarian cancer, which is one of the most common causes of death from gynaecological cancers. So, Usha.
Thank you, Judith. Thank you. Good afternoon, everyone. It's a real pleasure to be here. The whole team is delighted to pause in our journey and share our story with you. On Friday, the results of the UK collaborative trial of ovarian cancer screening was published in the paper copy of The Lancet. And we were delighted to see that there was an accompanying editorial which said that the successful conclusion of our trial represents a major achievement for clinical science in the NHS. The editors went on to say that by asking the right question at the right time, widespread collaboration is possible. And indeed, UKC Talks is a huge collaborative effort. At the core are over 200,000 women who took part in the trial. And then there are all the funders who came together to help us run this trial. There's the oversight committees and then the research teams, both here at UCL and at the 13 centres around Northern Ireland, Wales, and England. And all the NHS trusts and the universities that supported them, and the NHS staff and the GPs who helped us take care of the women who developed ovarian cancer in this trial. But before I tell you about our journey, just something about ovarian cancer for those who may not be familiar with the disease. I did not realize when I first started that, of course, there were people from all backgrounds, and it may not be a disease that's familiar. So just to clarify, ovarian cancer is a cancer that is seen in women, which arises from the tubes and ovaries in the main. And as Judith said, it's the most common cause of death from gynecological malignancies in the UK. So every day we have 20 women being diagnosed and 13 women dying. So once diagnosed with the disease, only about 1/3 of the women survive 10 years. And this is in the main because most of the cancer is diagnosed when there's very advanced disease, widespread in the abdomen. And the women are in stage 3 and stage 4. This, as you can see, is associated with poor 5-year survival. There are, however, some women who are diagnosed with stage 1 disease and stage 2, and they do much better. They respond to the treatment. And our whole rationale for screening is to try and pick up this advanced disease earlier so that our treatments can make a difference. So the journey starts a long time ago, really in the early 1980s, in 1981, and really it starts in the US, in Boston, in the Farber Cancer Institute, where Bob Bast and Bob Knapp discovered CA125. So CA125 is a protein that's naturally produced in our body, but ovarian cancers produce large amounts of CA125. So they went on, having discovered this protein, to describe a test to measure the protein in the blood. And by 1983, this test was available. At the same time, here in London, at King's College Hospital, Stuart Campbell had started looking at the ovaries of postmenopausal women. He was looking at their size in real time and how they appeared. And he felt that ultrasound too could be used as a test to try and pick up this disease earlier before women had symptoms. So he started off recruiting women to a trial of ultrasound screening to pick up ovarian cancer. And in those early 80s, he recruited just under 5,500 women, and he offered them 3 annual screens. Only about 5 primary ovarian cancers developed in these women, and they were all picked up. But a lot of surgery was done for each woman who had ovarian cancer diagnosed. Another 66 women underwent surgery and removal of the tubes and ovaries because there was a concern whether what was found in the ovary on ultrasound might be an ovarian cancer. But what it did show was that, like a proof of principle, that ultrasound too could pick up ovarian cancer before the women were aware. Nina Einhorn was working in ovarian cancer from the Karolinska. She had been in contact with Bob Bast and decided that what was now needed is a prospective evaluation in real time of CA125. So she recruited about 5,500 women, did their CA125 levels, and then 175 of them had an elevated level. And then she got another 175 age-matched controls with normal levels out of that big cohort, and then followed them forwards with pelvic examinations, abdominal ultrasound, and CA125. Because the number of cancers in this whole cohort, again, was small, 9 cancers, you cannot really comment on how good the strategies are for detecting ovarian cancer. But what was clear was that if the cancer CA125 was normal, the risk of having an ovarian cancer was low, and the test had high specificity. Ian then, and before I go on, can I just say that the pictures that I'm using are of all these people as they are now. They were much younger in those days, so Stuart did not look like that, nor did Nina. And Ian, this is his photograph now, Ian Jacobs. He was in his late 20s, a junior doctor, and so probably didn't look like this. So a junior doctor at the Royal London Hospital at Whitechapel. He was really determined to make a difference with when it comes to ovarian cancer. And he went across, did some work with Bob Bast, came back, had communications with Nina in Stockholm. And Ian is always very ambitious and always thinks very big. He thought 5,000 won't do. So he planned a trial of 22,000. He recruited 22,000 women aged 45 or over between 86 and 1990 while he was doing all his clinical training. And he offered them CA125. Their level was more than 30. He then offered them an ultrasound scan. And it was clear that he could pick up, using that strategy, about 76%, so 3/4 of the cancers that were diagnosed within 1 year of that screen. And 3 women had surgery, unnecessary surgery. They did not have ovarian cancer for each woman who was diagnosed with ovarian cancer. Just to clarify, unlike breast cancer, where if you had an abnormal screen, you can do a biopsy, in ovarian cancer, you cannot do that. You need to do surgery and remove the tubes and ovaries if you suspect ovarian cancer. If not, you change the stage of the disease. Then the next player in the game was Steve Skates. He was a young statistician working with Bob Knapp in Harvard. He was very interested in serial CA125. So he had this data from Stockholm. Few cancers, 9, but lots of serials, more serial samples in normals. And he was interested in looking at the profile. It was clear that women who didn't have ovarian cancer, they had like a straight line. Their CA125 ran flat. And women who were developing ovarian cancer, they had what he called a change point. But he did not have enough data points to go beyond this. Ian finished his first study and went on to the next study, where he randomized the women into a control arm, these 22,000. So 10,000 control arm, no screening, and 10,000 screen arm with screening every year for 3 years. At the end of this, what was clear was that a CA125 was a very strong predictor of whether you had ovarian or tubal cancer. And also as a result of this, he had nearly 48,000 samples, CA125 results on these 22,000 women. Just what Steve was looking for. So Steve comes over to London, and in the summer of 1994-95, they worked together and they developed this risk of ovarian cancer algorithm. And what that algorithm does is it looks at a woman's serial CA125 levels and fits her profile between the profiles of these women, some of whom who have ovarian cancer and have this change point, and others who may have raised levels but have very flat profiles. and it estimates a risk. So if you put in the CA125 levels in a woman's date of birth, it gives us a risk 1 in 20, 1 in 3,000, 1 in 5,000, and you can then decide what you want to do next. At this point, I was almost finishing my clinical training in general obs and gynae down at George's. And I had been following the Bath story for a long time, and it seemed to be developing in a very interesting way. Ian, in the same year, having done all this work, had just finished his subspecialty training and was about to become senior lecturer in 1997. And he advertised a job for a research fellow. I think I must have put in my application first among those who answered the advert. But unfortunately, I didn't get the job. You know, I had not done any massive research before, and so I didn't get the job. But I was so impressed by Ian's vision, and he was not deterred by any obstacles. This is what he had to do, and it would be done. So I told him I'd come out of my clinical training and work without a salary for a year, and we'll see how it went, and hopefully some grant would appear. And the first thing I did was I started looking at this ultrasound data from the 22,000. So a lot of work had been done on the CA125, and this ultrasound data were all on flashcards, lying in piles in filing cupboards. So we had to enter it all. But it was clear that, you know, Ian had previously used volume as a cutoff to say it's a normal, it's an abnormal ultrasound. And it seemed like if you had looked at the appearance of the ovary, that might have worked better. So we decided to change the strategy. And we now had a strategy where we were going to use this new ROC algorithm to stratify the women into low risk, intermediate risk when they'd have repeat blood tests, and high risk when they'd have a CA125 and a scan. And we were going to interpret the scan using the new criteria. And of course, we had to start with another trial. So we started a feasibility. Ian had already started a feasibility, and I started working on it. And as it ran and time passed, it was also time for the Bath's earlier trial to become mature. So we now had 8 years follow-up on that initial trial. And based on that 8 years follow-up, it was clear that there was a significant difference between median survival in women who were diagnosed with ovarian cancer in the screen arm versus the control arm. But as you can see, the numbers are very small, 16 women versus 20 women, so it's like preliminary evidence, but really does not suggest that there's a definite mortality reduction. So we were at a point where everything had been done and we had to take the plunge. We had an acceptable strategy which was feasible to implement with a low false positive rate and a suggestion of a survival benefit. So the plan was that we would take the plunge and we would go for the big trial with ovarian cancer death as the outcome measure. And because we wanted to finish the trial, but do the trial such that the NHS could decide whether there would be a screening program similar to breast and cervical, we also wanted to answer the questions of would women come year on year? What would the cost of all this be? How much anxiety would we introduce in women who were told to come for repeat tests? And in these women who were having false positive surgery, what was the complication rate? And to do this, we had to now expand the team. And Ian and I were often on the tube and in the train and in the bus going up and down. We asked Max Palmer, now professor here, institute director here, who was then at Cambridge, to come and to join us as a trial statistician. Ali Maguire joined to now at LSE to look after the health economics aspects, and Leslie Fallowfield, now at University of Sussex, to look after the psychosocial aspects of the study that we wanted to take forward. And of course, Stuart Campbell had already done a lot of work in this area and was part of the team. The trial we planned was a 200,000 trial with 100,000 women randomized, not having any screening. They will be our control group for comparison. And then in the study arm, we split the study arm again into two groups. One using the ultrasound strategy, which was first-line ultrasound, and the other, the strategy I spoke to you about, which we had been working at Bart's, the multimodal strategy. And the plan was 6 annual screens, and every woman censored for death from ovarian cancer, 7 years from randomization. We set up 13 trial centers agreed to join us in this effort. And my first task was, we were just 3 on the ground at Barts. There was Ian, and then there was Karen Sibley, who was a senior nurse, and myself. And we were going from a 13,000 trial to a 200,000 trial. It was like, we had to really, in 6 months, change things drastically. And the first thing that was clear was that we needed to have a trial management system that could really manage this whole trial, and we could safely conduct this screening. And at that time, it was not like now that where a lot of clinical trial systems, we could have taken it off the shelf. This was 1999, 2000. So in fact, we went to a company, which was a Lloyd's, which all the expertise was in Lloyd's shipping for them. But they did build us a wonderful trial management system, and I think a lot of our success is because of this system that we built together with them. The research lab was doing CA 1 to 5 levels. Now we had to go again to another grade. We didn't want to send the CA 1 to 5 to the NHS. We worked it out that it was cheaper if we did it ourselves. So we had to go for CPA accreditation. And if any of you have been on the NHS side or in a lab, you know how painful that is. It was a whole different thing for us. We had never taken a lab in for clinical accreditation, but we had to do it because the CA 1 to 5 was going to then determine whether women had surgery. And then, of course, we had all these large-scale trial logistics to set up. We were planning to send out, in the course of the study, 1 million invitations from our center and all the results. And then we had to set up the accreditation and the training for the ultrasound. And now that we had a more, we needed to have a bigger team. Barts gave us more space in the old anatomy building, now at Charterhouse Square, in the in the Queen Mary campus. And a number of people joined the team. And I just want to highlight the names of a few people who have made a critical difference to where we are now. And among them are Andy Ryan. I think among all the people who, if they went under the bus, the trial would be at risk, Andy is number 1. He is the highest priority in our group because he knows the data, all the disaster recovery plans for the data and manages all the data. Rob Liston is the brains behind the trial management system. Alex Gentry Maharaj, Senior Research Associate on the trial. Richard Gunu, who has done all 350,000 CA 1 to 5s on the trial. Sue Davis, who has probably spoken to 10,000 women, I think, on the trial, just because they ring her all the time. She's a senior research nurse. And I think the person who has spoken to the most number of people on the trial individually is Sheila Spicer, who manned the phones for all 10 years of the trial. We were having like huge number of calls every day. And soon Sheila knew many women by name because last year they had changed their appointment 4 times. So this year they were starting to change their appointments again. And so each person made a critical difference to how this trial went on. And so we had in the basement of Barts this recruitment center and tumor marker laboratory. We had our offices in the old anatomy building across Charterhouse Square. And there was a lot of toing and froing and a lot of brainstorming in the pubs in between, in Smithfield. So each one had a favorite pub. So depending on who was leading the brainstorming session, you'd had to go to their favorite pub. And then it was really a lot of brainstorming because what was clear was that we needed to recruit 120 women per center per year, assuming that they would work 44 weeks in a year. And there was no leeway because the centers were going to be paid per women recruited. And if we did not recruit as we had planned, there would be no salaries and no money to pay the salaries for the research staff at the centers. The MRC was only going to support the research staff here at the center. So we ran really tight monitoring and logistics, and sometimes things were bad at a center, and the whole team from here would go and do additional clinics on the weekend to help get up the numbers. And to try and make this a bit smoother, 200,000 women informed consent, though we sent it printed material out. We thought we'd make a recruitment video as well. And it was a video, it was not a DVD at that time. And of course, we hadn't thought about it when we wrote the grant, so we didn't have the money. Eve Appeal is a charity that has always supported us outside the big publicly funded bodies, and they immediately rose to the request. We had some money, we had a BBC director who would make the video for us. Of course, we had no money for actors and actresses, so everybody who had a mother or aunt or a grandmother in the 50 to 74 age group living in London, then pressurized them to come and be part of our video. So this went on, and things seemed like were going well. We were recruiting, not too bad, reaching some targets. The ultrasound started, they were scanning at the centers, entering the data live onto the management system. Centrally, we were allocating, running the algorithms, the results, the next steps. And on the ultrasound side, all the blood was coming. The blood was taken to the center, entered. It came overnight to us. Sometimes, of course, the plane did not take off at Belfast, and then there was all sorts of anxiety about the samples. But on the whole, it worked very well, and we did all the assays here, uploaded all the results into our management system, and things were going good. But what happened was, the women, in their generosity, allowed us to store the serum that was left after we ran the CA125. Of course, this meant that we needed to have space, money, and all the usual things to store the serum. The first question was, how should we store the serum? So I did a lot of looking around, and Steve Skates from Boston suggested to me that I should go and visit the French blood bank in Paris, because he said they're using some innovative stuff. So off, Karen and I went to Paris, and they were using these straws to store the serum. And this seemed like, at least from a space point of view, a much more effective way of storing aliquots. So we got the system and set it all up in the basement of Baths, in the East Wing. And we had 3 freezers and 500 to 600 samples coming every day, each being aliquoted into 10 aliquots. In no time, Jeremy, who was running the lab, was like, Usha, we are going to run out. He was behind me saying, what am I supposed to do? This is all kind of filling up fast. And we really didn't know. We were in the city. Where would we go to find a place? We had the money to buy these big, large liquid nitrogen tanks, but we had no space. But of course, and this is why I say that UKC Talks, we have always been supported by a huge team, which is more than the core team. In Charterhouse Square, those of you who know it, there's a very nice garden in the campus, but it's all very historic. But the estates team there were very helpful. They told me, Usha, there's a little gardener's shed. And we can do one thing. We can say that the gardener needs a bigger shed. It's a temporary structure, so we don't need to go for planning permission. And we can then, so we worked together with the team, and we brought this, and we put up this big gardener's shed, just to help the gardener help us. And inside the gardener's shed, we now had space for 9 tanks. And each of those tanks could hold 35,000 samples. I thought, what relief. Let's now have some peace. But Jeremy was behind me. He was like, no, these tanks are also filling up. And it was clear that we had space only for 1 more tank. And it was the end of 2003. But then again, good luck. UCL asked us, would we like to come over from Baths to UCL? So while Ian was doing all the negotiations, I told him, I need only one thing. They need to pay for this. They need to pay for some space to put these tanks. And UCL rose to the occasion, and they said they'll pay the rental costs for us to put all these tanks in a commercial facility. And so that was solved. The team grew bigger, and again, I want to take some names. Gwen really led the ultrasound accreditation. Aarti Sharma, Matthew Bonnell, who has done much of the analysis that I will present, Tindy, who took over as operations manager. And really, Catherine and Jazz, and before that, Jenny, who run the admin. We have thousands of invoices for like 50 pounds to be sent to the GP for each set of notes. That in itself creates hosts of invoices. And they took care of all of it and continue to do so. And now we have the research team, the research assistants who are really out trying to get the notes from all these hospitals. So by 2005, 1.2 million invitations sent, reached our target, 202,000 women recruited. But then we realized the women we recruited were too healthy. So in the control arm, when we looked at deaths in the control arm and we compared it to the age-matched UK population, it was much lower. So we were having less events in the control arm than we had expected, and so we had to extend the trial, move from 6 years of screening to screening till 31st December 2011, 7 to 11 years of screening, and then we had to increase follow-up till December 2014. Now, of course, this meant going back to the funding agencies, asking for more money, all of that. Everyone is supportive. But for the trial leads, it also meant going back to their CEOs in the trusts, because they now needed to ask for these 3 rooms we were using for the trial for a longer time, and you know how difficult that negotiation is when it comes to space in the NHS. The women had given us permission, all 202,000 women, so only 8 women had not, given us permission to give the NHS number to the Office of National Statistics. And regularly, we were getting cancer registrations and death certificates in these women. We also wrote to them so that we had good follow-up. And really, at censorship, we had 2.19 million years of follow-up. And so now to the results. So in our multimodal screening strategy, we had the women attended 81% of the appointments we sent out, of the screens that they needed to. So very high compliance and very good complete follow-up. We had undertaken 345,000 screens. And as a result, 736 women, 0.2% went to surgery. And on analysis, we were able to pick up 84% of ovarian cancers that were diagnosed in these women within 1 year of a screen. And we did 3 operations in women who did not have ovarian cancer. For each woman we detected with ovarian cancer. The other thing that was clear as we analyzed the data, having finished the screening, was that the use of the ROCA helped us pick more women earlier. And in about half the women we picked up with invasive epithelial ovarian cancer. We would not have, if we had used that cutoff of 30 or 35, we would have said their result is normal and send them back for a year's screening. So that was all very positive, because all this time we did not know what the effect was on mortality. So what we have now is the data on an intention to screen analysis, and what is clear is that there is a stage shift. So, the rationale was all built on stage shift. And what this data shows is that in the multimodal screening arm, about 36% of the women were stage 1, 2, compared to the control arm where 24% were. And this stage shift is significant. So the p-value, which is a test of statistical significance, it shows that this was not a random chance event. There was definitely a difference between the 2 groups. And so this is the core analysis. This is looking at deaths from ovarian cancer in the control arm versus the screen arm. Here are the years from randomization. And as you can see, by the end of 14 years, we have a 15% difference between the 2 arms. Now, we had 2 pre-specified ways of analyzing the data. This was our primary analysis, the Cox. And on that, our p-value was not significant. So this reduction could be due to random chance. What was clear was that in the first 8 years, we seemed to have only an 8% reduction. And in the second half, 23% reduction. So a difference, like a late emergence of reductions. When we did our second analysis, which was pre-specified, where we removed women who had ovarian cancer when they joined the screening trial, there was a difference which was significant between the two arms. We did a third analysis. This was post hoc. This was like after we had seen the data. But this was many would feel that this is the right test if you have this late emergence of an effect. And on the weighted log rank, the p-value was significant. The screening was not without harm. So about 1 woman for every 1,000 screens reported bruising, pain, hematoma, all these blood tests. And then 14 women in 10,000 had surgery for which, and they were found to have normal ovaries or benign adnexal masses. The major complication rate in these women who had unnecessary surgery was 3%. The ultrasound screening results showed similar high compliance and good follow-up. We did about 327,000 screens and much more surgery. So 0.56% of the women had surgery. We picked up 73% of the cancers in this arm, but did much more surgery. So 10 women had surgery and did not have ovarian cancer for each ovarian cancer detected. We did not see a stage shift in this arm. So this ultrasound, the cancers in the ultrasound arm, the stage was similar to the stage in the control arm. We had a reduction in mortality, but that was not significant. So the p-value was not significant either on the Cox or on our post hoc weighted log rank. And as far as the harms go, there were 2 women in 10,000 who had who complained of complication. 50 women in 10,000 screens who had surgery that was unnecessary with a 3.5% complication rate in those women. So just to finish off, we did look at one other thing. So what those curves that I showed you, that is cumulative mortality. That is counting the deaths from ovarian cancer, summing them up. These are the mortality rates. And when we look at the end of the trial, which is at this point when we did this analysis, what you see is that the mortality rates for ultrasound and for multimodal have sort of flattened out, while the rates of death in the control arm continue to rise. This suggests to us that if we follow up the women, then we will have more events, and this reduction may become more significant and more meaningful. And if you look at the prostate screening trial, when they first reported, they had a reduction of about 20% and a p-value, a significance value that was just significant at 0.05. On follow-up, it became highly significant as more events happened in the control arm. So what our next steps, which is why I said our journey is still not over, is we have to continue to follow up this cohort with another analysis in 2018. So where are we on this unfinished journey? We've found a test that's, in addition to being acceptable, feasible, having a low false positive rate, being one that women would continue to come year on year, so associated with high compliance. And in the multimodal arm, we've been able to pick up over 80% of the cancers diagnosed within a year with a shift in stage and encouraging mortality results, but that cannot be, we couldn't conclude that that is absolutely right. Lots of statisticians out there are, some for and some against with regard to the results and their interpretation. And we have our cost effectiveness analysis just going on, and that'll be out pretty soon. So this is here where we are 30 years down the line. Thank you.
Thank you so much, Usha. I think it's easy, even with that rapid journey through a 20-year endeavour, to see why the Lancet wrote that accompanying editorial about the truly outstanding achievement and contribution of this trial to science and to the NHS. So thank you very much for explaining that so beautifully. Including the garden shed, I'd forgotten that bit, so it obviously called on all your creativity and sort of cement laying skills.
Absolutely.
So we have time for a couple of questions. Hey, could you just wait for the roving mic? Thank you.
Hi, how will your research be translated into government policy in terms of screening for postmenopausal women, and does it have the same impact that breast cancer screening has?
So with regards to the NHS cancer screening group, they are going to look at the paper in May together with the cost effectiveness analysis. We have, but the truth is that is something that they have decided. We personally feel that because we have this we have the statistical significance on one analysis and we don't have it on the other, that it is a bit early to say that we definitely have to have a reduction. And unless we definitely have a reduction, for them to recommend screening for postmenopausal women, which is not without harm, as I showed you, would be premature. So I don't know what, when they review what they will say, but from some preliminary discussion, my understanding is that what they want to do is start getting prepared for a possible definite answer when we do our next analysis. So if we were, as you know, for any screening program, if we were going to implement screening, we would need to have everything downstream sorted. A clear treatment pathway, everybody, all the women, women who have false positives should have timely surgery as well, because until we do the surgery, they don't know they don't have ovarian cancer. And the whole treatment pathway, as well as the provision of CA125 and ultrasound, all should be sorted. And Dr. Anne McKee, who chairs the committee, feels, I think that is why they're looking at the data, just to see, do they feel that this will be positive? Independently, they will review. And then if so, what should they do to prepare for it?
And you will at least have this extraordinary experience over 20 years of what's needed to mount a screening program like this. Any other questions for Usha? Yes, right at the back in the middle.
I understand, I'm a bit confused about CA125 because I understand that it can get raised and there is no ovarian cancer. So basically, what I would like to know is what causes the CA125 to go up if there is no ovarian cancer?
So, like I said, CA125 is a normal protein in our body, and it is produced by cells that arise from the Mullerian epithelium. So, you know, many of conditions which cause any inflammation in that area could also set this up. So, you will see small rises, though not at these levels, at very high levels in endometriosis, during pregnancy because it's an oncofetal protein, during some diseases like if you're having any sort of pleural or peritoneal inflammation. So the levels do go up slightly in other diseases. It's not a absolutely ovarian cancer specific marker, and also in some cancers like pancreatic. But the level keeps, so that is why we use this risk of ovarian cancer algorithm, where we are looking at a rising level. In many of the benign conditions, the level is higher, but flat.
Okay, thanks.
Time for just one more question, if anyone would like to pose a question or comment. Right in the middle. Yeah, thank you.
Hiya. I was just wondering what sort of setting that they were recruited from. I think, did you say some of them already had ovarian cancer when they were recruited, or was it when they were at a GP? Or
No, so the women were recruited through the NHS age-sex registers. So that is why we invited 1.2 million women. So in all the primary care centers, and I don't know if the data protection law would allow us to do that now, but at that point, we negotiated with the Caldecott guardians of all these centers. And every week, they would download to us about 5,000 women's names, addresses, and their GP details and their date of birth. So we then wrote out to all these women. So when I say some of these women may have had ovarian cancer, it's like in this, like all of us, you know, I may not be aware I have ovarian cancer, but in a year's time, I might present, and we know that in ovarian cancer, you know, women can not have very many symptoms. So that is how we did the analysis. Not that they knew it. If they knew, they couldn't join the trial.
Thank you.
Okay, I think we'll have to leave it there because we've come to the end of our time. But please join me in thanking Usha again for this amazing study on behalf of her team and for the amazing results and the tantalising results that are going to come in the future. Thank you very much.
Thank you.